So good morning, everyone, and welcome to our first Diversity Dialogues panel discussion of 2024, which is entitled Exploring Challenges Around Cancer Diagnosis and Treatment in Culturally and Linguistically Diverse Communities. I would like to start this morning by acknowledging the traditional owners of the land which I am on today, that is the Whadjuk people of the Noongar Nation, and I pay my respects to elders past, present and future. I extend my respects to any Aboriginal or Torres Strait Islander people on the Zoom today too. I'd also like to acknowledge the impact of colonisation and say that before we go discussing any other health inequities this morning, we must acknowledge the significant disparity in health outcomes experienced by Aboriginal and Torres Strait Islander people. Next, just some housekeeping. We will keep everyone on mute for the duration of the webinar because we've got quite a big group today. We've got over 80 people registered. I'm not sure if everyone will join us on this fine Monday morning, but I think it's best if all the participants stay muted. And then if you have a question or comment to make, can you please use the chat feature? I've got a couple of colleagues monitoring the chat, so they will reply you there. We didn't get many questions pre-submitted on registration, so I'm going to ask a few questions of our panelists and we'll have just over an hour of discussion. And then I'll open up for audience questions to see if you've got any. It's your choice to have your video on or off if you're not a panelist, but we'll keep the videos on for the panelists and spotlight them to make the session more interactive and enjoyable for you. For anyone who doesn't know me, my name is Nadine Lalji Curran, and I'm the Cultural Diversity Engagement Lead at the Health Consumers Council. We are WA's peak body representing consumers in healthcare, and we strive to make sure that our patients, carers and families are at the heart of the state's healthcare system. And this event is brought to you by us and in conjunction with the Cancer Council of Western Australia. So thank you to them too. In the most recent burden of disease study conducted in 2023, cancer once again was number one, causing the most burden at 17%. And although in Australia we have some of the best cancer outcomes in the world, it's still a heavy burden and it's not evenly spread. People from multicultural communities, broadly speaking, tend to have poorer cancer outcomes. People from multicultural backgrounds face numerous challenges in cancer prevention, screening, and early diagnosis, as well as accessing appropriate treatment. We know from research that a couple of the main barriers to care are language barriers and navigating the Australian health system, as is the case with all health issues. But with the chronic and complex nature of cancer, this makes this issue even more prevalent. Furthermore, with cancer, there are feelings of embarrassment, fear, shame, and fatalistic views of cancer, plus screening and cancer information not being provided in community languages. Now, I know you didn't come to listen to my voice and hear from our wonderful panelists instead, so I will stop soon and let you hear from our panelists. But I did want to just quickly draw your attention to some recent work by the Department of Health, if you've not already come across it. In 2022, the Cancer Network Western Australia Department of Health undertook a project called the Culturally and Linguistically Diverse Cancer Information Needs for Consumers and Carers, a very long project title. And that project was part of the WA Cancer Plan work, which identified a need to provide consumers with more reliable cancer information. The Department of Health partnered with 5 community organisations, of which Health Consumers Council was one, and Umbrella Multicultural Community Services was one. Another one of our panellists is from Umbrella. And between us, we spoke to 175 patients and carers. During this discussion, we heard about the importance of primary care and that people were often relying on their GP for cancer information. That cancer patients and families struggled with overwhelm, particularly when in specialist appointments, and an opportunity to ask questions, as well as an opportunity to return to things and written summaries were key. We heard about a real lack of translated resources and about some of the problems around using interpreters. I won't go into too much detail, as you can read the report, and one of my colleagues will share the report link in the chat. But just to say that my colleagues Kieran Curtida and I conducted numerous interviews, and personally we found it to be a real privilege to hear about people's experiences firsthand. And that's what motivated us to organise this event today. We thought it would be good for others to have an opportunity to hear some firsthand information from consumers and carers, which can help guide them in their work and practice. Today we'll be talking about the experience of cancer from multicultural communities, largely by hearing lived experience perspectives from those from communities. We'll talk about community views, perceptions of cancer and undergoing diagnosis and treatment in Western Australia, and how that experience might be and how it might vary from people from various multicultural backgrounds. So lastly, before I go to the panelists, I'd like to give a recognition of lived experience. Sharing lived experience requires incredible vulnerability and also strength. Cancer is a journey which touches lives in profound ways. Survivors exhibit remarkable resilience, caregivers provide unwavering support, and the bereaved carry cherished memories. Please, when making comments and questions, do so with respect and sensitivity for all of our panelists, but particularly the three of whom are sharing their personal lived experience today. Thank you. And now I will kick off and let our panelists introduce themselves, because I definitely won't do them justice by doing that. So I'm going to start off with Henny, please. Could you tell us about your work in the CaLD community, please? Henny, introduce yourself.
Good morning, everyone. I'm Henrietta from Umbrella Multicultural Community Care Services, and I'm currently the operations manager, soon to be the new CEO. We have been involved with communities for the last 25 years, primarily focusing on our older communities, and specifically the Eastern and Southern Europeans. However, we do see changes in regards to the upcoming newly and emerging communities as they age and they have an increased care needs. In 2022, as Nadine has mentioned, there was a great project that we also were part of, and we have interviewed over 100 clients and staff members in regards to their cancer journey from 7 different communities, and that was a great learning opportunity for us as well, how information provision is happening or not happening in our communities, as well as some of the barriers, both systemic as well as from individual perspectives are preventing people to access the right information on time. And that was a great learning curve for us. And this is why we're still continuing with Health Consumer Council of WA to work on these important measures, especially in regards to developing relevant information for our communities. Thank you.
Brilliant. Thank you very much, Henrietta. I'm going to go to Hafida next. You're next on my screen. Could you introduce yourself with a little bit about your cultural background and a brief overview of your cancer journey, please, Hafida?
Okay, can you guys hear me? Yeah.
Yes,
Assalamualaikum. So my name is Hafida Iradat, Malay Muslim, born and raised in Katanning. Parents are from Christmas and Cocos Island. Currently working for Badge-Butt Aboriginal Corporation Connect Beginnings program manager. So my duties is to provide all children with a great start by improving their well-being prior to school and other services. I represent the CaLD community, the MDHAC, for the past 7 years. I'm also an end-of-life doula. So end-of-life doula is I offer assurance support, options and education, allowing people to make informed choices and allowing people to make choices, informed choices that aligns with their values, their culture, their wishes and needs, and take back control of their lives as they choose. So my cancer journey, it's actually 10 years in June, like my mum's cancer journey. She was diagnosed with breast cancer when she was 50 years old. The day Steve Irwin died, I think she was more shocked that Steve Irwin died than, you know, her diagnosis. Very, very young. Yeah, so that's a little bit of, and also my dad was also he had kidney cancer as well, but before he had kidney cancer, he had a stroke. So lucky, or, you know, not very lucky, if he never had the stroke, we would have known that he had kidney cancer as well. So yes, that's Hafida.
Thank you very much. Leon, would you like to introduce yourself, please? Thank you.
Hi, good morning, everybody. My name is Leon Wang. So I'm an academic staff at the UWA, lecturing in Chinese language and culture. My wife and I, my wife passed away at the end of 2021. We both from China. First, we went to Europe in Belgium and finished our education in Belgium and worked there for a couple of years, and we migrated to Australia. So we are totally pure Chinese-born scholars here. My wife worked, she passed away, and worked as a research officer or at the chemistry center of WA, and she was also as a research fellow at UWA too. So unfortunately, my wife diagnosed as the cancer in I think it's 1996 advanced stage. So we all went through this kind of trauma, and anyway, it was a lot of maybe story to share, and I think already done a lot of work with the community Chinese here. So share my experience as carer. So hopefully we can exchange some views on this.
Thank you very much, Leon.
Thank you.
Samira, would you like to introduce yourself, please?
Can't hear.
You need to unmute, please, Samira.
Unmute from my side. Yeah. So good morning, everyone. My name is Samira. My cultural background, I'm Kurdish from Kurdistan, northern Iraq. I have 3 kids. I have a master's degree in biotechnology and a bachelor degree in microbiology. Right now, I work as a research assistant at biotechnology. So since I turned 35, I've been visiting my doctors every 6 months for regular checkup to make sure everything is okay. In 2015, I felt something hard in my left breast. So I went to see my doctor to get it checked out. After checking me, the doctor thought everything was fine. But just to be sure, they sent me for ultrasound. Even though the ultrasound didn't show anything wrong, they said it's a benign tissue. But I still wanted to see a specialist in 2015. And then they sent me to the Fiona Stanley Hospital, where they did more tests, including mammogram, another ultrasound, and also at the end, they did biopsy. Unfortunately, the biopsy confirmed that I had a breast cancer. It was really a tough time for me. After that, I had to have 2 surgeries, mastectomy and axillary clearance, which is 1 month apart in 2016. Then after that, I had to go through chemotherapy for 6 months and 5 weeks radiation therapy. And then I've also been taking hormone tablets since then. I have to be continuing for 10 years. Yeah, then I had reconstruction surgery as well for my left breast. And this year, it's been 9 years past my diagnosis. Yeah, that's about it.
Thank you very much, Samira. And
Bye.
finally, Soy, would you like to introduce yourself, please, and tell us a little bit about the work you do at Cancer Council?
Sure. Hello, everybody. My name is Soy, surname Yao, and I have joined Cancer Council since 2008 while working in the hospital at the same time. So I was working part-time in 13, 11, 20. At the time, it was known as Helpline. And so with the work that we do, I would sum it up as such as never a dull moment, expect the unexpected, because come the word go from 9 o'clock, the phone lines open, we will have phone incoming calls come in. So we'll speak with whoever's on the other side of the phone and then go from there. Now, having said that, we'll also have to look at messages that would have left from last night, and we have to do the callbacks in between the incoming calls. And on top of that, we will need to look at the email because we would have questions flowing in on our question side. So we'll have to tend to and respond to the email, which would have come from whether it could be cancer patient or family and friends, health professionals. And so in between incoming calls and calling back, we will try to respond to the email as soon as we possibly can. And on top of that, there would be flowing in messages from our receptionists that we will have to sort of keep that eye and do the callback as well. So in the interim, I can give you an example, a few examples of my calls in 13, 11, 20. I could have newly diagnosed patient phone in crying and said, I am so confused. I don't know what to do. She was in a state of shock because she had just been told by her specialist she has cancer. Then I might have a call that comes in from a young mother with young kids and say, I'm not so worried about myself, but you can hear her tone of voice. She's definitely in distress. But she said, I'm more worried about my children. I do not know how to tell them about my cancer. What is going to happen to them when I am not around? Then I would have another phone call coming in from a guy in his prime, just been told by his specialist that his cancer has spread to other part of his body. And he did not know how to disclose to his dear ones. He's very scared. And then I would have another lady phone in and saying, I need to have my will drawn up because I've just been told by my specialist I only have 3 months to live. And on top of that, I would have also from the general public, like I have a young lady phone in. She was convinced she already has cancer because she felt a lump in her breast and she was beyond herself. And I have another guy phone in and say, I have passed some blood yesterday, but I'm okay today. I feel all right. Should I wait for a while, a couple of weeks or a few days, see whether it would happen again? So this is early detection and with symptoms and things like that. So with all this call that would sum up, there's so many other patterns of call I can go on and on and on. Basically, with all those calls, it might probably end up with professional counseling's referral. And some of them could have touched on sexuality issue that would have to refer them to the specialist counsellor who's specialized in this line of sexuality, and pro bono service for simple legal issues. And sometimes they might end up with support and services requests as in like financial practical. By the way, our practical has phased out and the financial program would eventually be phased out and we will roll in something else more sustainable. And so it is an ongoing thing. I will touch on the CaLD community later. So otherwise I'm going to drag on. Yeah.
Thank you very much. So I'll definitely come back and ask you quite a lot more questions about your work. Just to say, obviously it does not sound like an easy job, so I admire the work you do. I think I'll actually just move to hearing a bit more from the consumers at this stage. So Samira gave us a little bit of an overview of her diagnosis. Could I ask Leon and Hafida to talk a little bit about the cancer diagnosis part of the journey and the immediate response from yourself and the people that you cared for? I don't mind who goes first. Hafida, you're unmuted. Do you want to start us off about diagnosis?
Am I muted? Oh, I'm muted. With diagnosis, so it was a bit of a shock, you know, because we live in the country. So, you know, 4 hours, no, actually, the van. So that's where mum took her screening for breast cancer, and then got the phone call.
Oh, the van, the traveling bus. That
Yeah.
does this. Yeah.
Yeah.
Okay, great. Thank you.
Which is really, really good. But you know, she was 50 and I think, yeah, over 40. So we thought we'll go and, you know, we'll go and have a check. But once she got that phone call straight to Perth, so that's quite stressful, because when you get diagnosed, you will need to actually pay. Like, we had to go to months. Is it months? Like, I don't know. I can't remember the breast. Where you do all the scans.
I actually
Breast
don't
screen.
know. Sorry.
Yeah, the breast screen.
WA, breast screen.
Yes, and with that you need to pay up front. So not, you know, so financially as well. Mum had to pay up. You know, mum and dad, you know, wasn't in a high income, but had to pay that first. I mean, you still get the rebate, but it was like at least $700-800. But you know, just found out that you got cancer, you'll do whatever it takes, whether you've got to pay or whatever, to get the results. Once got the results, she went in straight away. So what I love about you know, with that service, women are seen ASAP. They don't stuff around, which is really, really great. Yeah.
Good. That's good.
Mm-hmm.
Okay. Thank you. Thank you very much. And Leon, anything you'd like to tell us about the cancer diagnosis and the immediate response for yourself and your wife? Leon, you're muted.
Okay, sorry about it. So, so my wife actually finally diagnosed at the nearly the end of 1996. But actually, the symptoms maybe came very early. It's early 1995. That could be 1 year, nearly 2 years earlier. Because one is the end of 1996, or the beginning of 1995. So one day in the morning, she woke up and suddenly told me she got a chest pain. So the pain actually not on the breast, like chest part. So then we say, oh, should go to see, you know, the GP there. The GP was male. So we went to see the guy. The guy just maybe have not really experienced in breast cancer. He just have a look. Oh, you got the inflammation in there. I'll give you the painkillers. You just go home. And she went home and took the tablets. It seemed to be temporary relief from the pain. Because my wife worked very hard, actually. She got a PhD degree there. She got all this research ground there. And then she just ignored everything. Maybe the light pain still there, still exists, but she ignored. She didn't pay much attention to that. The middle of the 1995, she got very bad pain again. And she went to the same doctor. The doctor said, oh, it's the inflammation again. So this time, again, it's just the painkillers. So didn't do a real medication at all. And she took it and seemed to be temporary relief again. And then the symptoms seem to be come and go all the time. So it's not really disappeared. Especially could be at night, getting the worse. She thought is because of the age of the menopause, maybe have other, any symptoms could be normal. And then to the end of 1995, and she touched, the armpit, found something there is hardened, there's a lump over there. And because we did not even think about the cancer, so also nothing to do with my family, her family, parents, grandparents, nobody got cancer. So we didn't really got any connection associated with this kind of, the lump with the cancer. So still ignored it. So early 1996, so the lump getting bigger. I mean, the armpit part, the axillary one. And then she thought maybe we get a second opinion. So change another GP, which was my family friend, is a lady. The first one is a male, twice for just inflammation there. But she still worked too hard, so ignore that and delay so much time until the August. Maybe as far as I can recall, it could be the July of the 1996. She said, when I finish this conference in China, I'll definitely go to see the female doctor. And then she did it when he came back to Australia from China. Then went to the female doctor. The doctor just touched the armpit part. And of course, I forgot one information there. So at the middle of 1996, so got another lump on neck. So they went to the female doctor. The doctor just touched both armpit part and the neck lump. And the doctor was very suspicious of the cancer because the age is sensitive. Menopause and in 50s. And the doctor said, "Oh, need a biopsy." Then she maybe took something there and went to the biopsy there, and the result turned out to be a cancer, but we do not know where the cancer is. Then we checked online to find all kinds of specialists. So started from head to neck, and went to see the doctors. They direct us to a lot of just the medical imaging there. First for stomach. I think also that she did maybe the brain part. Then we go to stomach and then breasts. Nobody. So any images, including TET, everything there, they did not find anything. So this called it turned out to be called occult breast cancer. So we couldn't detect the prime. I think they really pretty certain make sure it was a breast cancer. Could be the November. So we found the tissue there with with the cancer cell there, and it was not really identified the late of November. This is 2 months. This 2 months is very stressful because we don't know where the cancer is. And even on November there, we still do not know what the cancer is. Anyway, they check the cells, they thought the breast cancer, and then the doctor would be recommend to treat this kind of disease as breast cancer. And then we have a lot of options. So first, maybe the traditional one there, such as Gardner. And then my wife heard that another clinical trial from a friend. Actually, ironically, my wife, the story is very strange because she was quite well known for research, maybe in trying to find the kind of drugs to treat breast cancer in early 2003. She got the grant from the government. I think the media in Australia reported that. That's why she thought she was familiar with the traditional treatment. They thought, oh, maybe we go to clinical trial, the new one in Fiona, and then she took the option to go to Fiona. So that's I think the story of a diagnosis. So early the history is quite stressful there, just because we went to different places for imaging and get different specialists. So they can give all different opinions. So finally, they did not find the primary, but find out it was breast cancer. That's all diagnosis.
I'm really sorry that it was so stressful for you and that it took so long to get diagnosed, Leon. One of the things that you mentioned quite a lot when you were talking there was about the male doctor and the female doctor. Is that because you feel that
So actually, we've got another business with the male doctor. I think he already worked as a GP so many years. As a lady in 50s, I think got lump and arm. Actually, my wife didn't get any lump on the breasts. It was gradually very small in the beginning, and armpit. I think the male doctor should have already had any kind of thought could be breast cancer. But instead, I think maybe he got too many patients waiting for that. That's all inflammation there. Oh, that's the big trouble there. But the female doctor is much better. She immediately thought could be a female one actually is our family friend, is also Chinese. The first one is also Chinese. So usually we do not have a language barrier, but as a Chinese,
you usually communicate in Chinese when you're having
with a Chinese background. So generally we feel more comfortable, even we don't have language problems. So that's why the first guy also with the Chinese background. The second is a lady. So we are really grateful for the lady. Otherwise, maybe she passed away in 1997 because we did not realize it was cancer.
I'm so sorry. I was going to ask about communication issues, but interesting to know that you're using a GPs who speak your own language. Henrietta, can I ask, when you were doing the cancer interviews in 22, did you have any reports of a late diagnosis, like people who were not diagnosed early? Is that something that you came across at all? Henrietta, sorry, I don't know if you heard me say your name or not.
Yes, thank you. I just couldn't unmute myself for some reason. The system prevented me.
Always the way.
Yeah, I don't think it was many late diagnoses per se, but people were hesitant to definitely engage with the system when it comes to, because they didn't know how to express, or it's really often not came down to an emergency. I remember this from particular community. And then again, when we talk about multicultural communities, it's not a homogeneous group whatsoever. And we're not even just talking about multicultural, multilingual, and multi-faith Australians. We're talking about their family members visiting. So one thing that really stuck into my mind, that was a very late diagnosis, which literally ended up on like a trial of a drug because, well, it's too late now anyway, that was sort of the preface that the family got. A gentleman visiting her daughter, and that was in the Hungarian community, visiting the daughter, and he had some sort of episode, and then they went into the emergency, and then they diagnosed with like end stage. And then he actually stayed for another 3 months because they offered him like a treatment plan, which actually enabled him to diagnose, but then they went back. So we're dealing with not just delays in diagnosis here, but also us people coming into the country. They may already have the cancer, they just don't know, or they're visiting. So that was one of the things in Australia, actually, they actually picked it up here, but still that was considered as a late diagnosis per se, because that was an end stage. Yeah.
Thank you. I think that's a good segue to talking a little bit about navigating what's quite a fragmented and difficult to understand system. Soy, when you're on the telephone lines there.
Say, something about the system. I think when my wife first, biopsy result for cancer there, we're really concerned. But we went to the public hospitals. They all just rejected. They said, "Oh, if you do not diagnose as what type of cancer they are, don't come here. So then we have to, then we have to go to a lot of other specialists, and they just refer to go to different medical imaging there. I think the system there is the public hospital itself maybe swamped about 2 million patients. Sometimes they are very impatient to even to have an interview with us. So if you don't know what kind of cancer, don't come here. So we got very annoyed, sometimes stressful for that.
But you were given an appointment, Leon, at a public hospital with an oncologist, and then
I
you
think
felt they weren't receptive.
yeah, she went to the Sachas Gardner there, and also, okay, you have the, we don't know what kind of cancer there. So we already, my wife cried. So I already, already distant, it's we're not sure it's distant or not. It's our neck, okay. But one of the specialists for, I think for the head and neck cancer, he, from his experience, he thought it was breast cancer. So my wife said, "Oh, possibly I got breast cancer there. It's already, the distant spread there is already on the neck, so it's not threatening." And I think usually there's all the. I went to another hospital. I think it's could be Mount Bay there. So those guys say, "Oh, this may be developed many years." So you. What they mean is, relax. You just go there because this disease already exists in so long time. So it's not really like urgent. But my wife already cried because she's already here. So we believe because she was actually got quite a lot of knowledge of, the cancer itself, but she did not even think that she herself would get it. That's the trouble there. Yeah, she got a big knowledge of that because she did research on that. Research on the treatment.
But you never think it's going to be yourself. Yeah.
So we did have some problems with the system there, which just usually could be make the patients even more stressful. So,
it's a difficult system to navigate.
So
I'm interested to know if you ever have callers who have trouble like navigating the Australian healthcare system.
Yes, this is from the multicultural community, especially. Community overall as a whole, yes, we do have issues there. And I think other than the language barrier, because the language barrier would lead to lack of voice. And on top of that, if they are not aware or not knowing where to go, who to ask, they are stuck. Then they can only talk among friends, and it's no better. I can give you an example. One case, working mom. She's actually from the aged care industry. She was complaining about pain, and she took time off to see her own GP. But she was sent back with some painkillers. So this has been going on back and forth for a year. Cut the story short, after a year, she was being diagnosed with stage 4 pancreatic cancer. Now, in hindsight, if she knows where to phone like 13, 11, 20, we would be able to hear her out and see which is the best way to navigate, including seeking a second opinion or a third opinion.
Sorry, but do you get many callers from culturally and linguistically diverse people, do you think? Or do you think
I do not get many calls from multicultural.
Not proportional, possibly. Yeah.
No, not proportionate, definitely.
And how do you think people are hearing about the service? Like, are they getting referred to Cancer Council from their medics or from their doctors?
Actually, this is interesting. Now, it comes like a wave. There are times it would be the health professionals, and then suddenly it dies down. And then it would be words of mouth from friends. And a lot of them actually saw our number, 13, 11, 20, on our publications, because each of our booklet, we would have printed out 13, 11, 20 in a very prominent way, and people would kind of take notice. However, I think, having said that, I think if 13, 11, 20 has actually been recommended from health professionals to the patient, they will phone, because in their mind, it is what the doctors tell them, and this must be the line that I should go. So I would encourage all the specialists, the GPs, allied health, to encourage their patient to phone us, because when they have questions to ask, they would have a drawback, as in, I don't know how to start. I don't know where to begin. Therefore, there is this hiccup, as in open up. And the open up is very important for the first time to ask the question, which a lot of times being shut down before it started. And not shut down by the opposite party, shut down by herself because of the unsureness.
I must say, when we were doing the interviews, we heard a lot about people just not knowing where to go, and to be honest, not getting referred to a lot of the community support services that are out there. So it's interesting to know that that's kind of what you're feeling too. Now, I've got a few other things that I thought of that I want to move on to, but I did notice your hand up, Samira, during the conversation about navigating the health system. Is there something that you wanted to add?
Yes. So when I first felt the lump in my breast, when I went to my first GP, she said, you know, it's a benign. And then after I went and 45 minutes ultrasound, the result came back still as a benign tissue. Then if I wouldn't stop at that point, the cancer would spread out all over my body. But in that period of time, it took 3-4 months for me to go and to other GP, to the hospital, and then I got diagnosed. When I got diagnosed at Fiona Stanley Hospital, and then it was December, I was under a lot of stress, and then I was happy to go under the surgeries straight away, because they said you have to do surgery first. But you know, one of the doctors, she told me, oh, that lump been there for 3 years already. Why you are in a rush? So that was a, you know, I don't know, very bad thing that she told me.
Sounds a bit like you told me before that it felt like dismissive to you, that she was like,
yeah,
you wanted it urgently removed as soon as you knew about it, and she was like,
yeah. And then I went, I sought another specialist to do a surgery for me. I went and I found out a specialist. I wanted to pay, but then when the specialist contacted the hospital for the results and all of the things, they said, no, this is our patient, you can't do anything about it. She has to wait next year.
But what I'm hearing from both yourself and Leon is that you really had to advocate for yourselves.
Exactly.
And like both you and Leon's wife were scientists who speak excellent English, etc. So just thinking about that people who don't have necessarily as much knowledge or experience advocating. And I did hear a bit from all of you about communication issues there, and thought it might be good to talk about that a little bit. Hafida, I know that you've mentioned some problems with both your parents when they were going through the diagnosis. So my understanding is that they did engage interpreters for your parents, but there was an issue when interpreters weren't allowed into the procedure room or similar. I remember you saying something about your mum's biopsy and the interpreter not being allowed in that. Can I ask you to elaborate on some of the issues around interpreters and the diagnosis, please, Hafida?
Yeah, so like certain things, like I'd use that as, you know, going through the CT scan, you know, with the breathing, because once you go into the tunnel, you know, he already can't hear, and also with the, you know, going in, he didn't understand. So, you know, the results weren't like clear, so we were there a bit longer. So if there was maybe interpret allowed, or even because sometimes I'm not allowed to interpret for my parents or for my dad. You know, so if going to, like, let's say,
What language does your dad speak?
Malay.
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 Okay, sorry.
And, yeah, but then bahasa like Kokos as well. So, you know, Malay could be, you know, Indonesian, Singaporean, we've got a different slang. So with the different slang, he also didn't understand to interpret it back because we got a different dialect. So that's why I also notice. Yeah. So with communication and interpreters, that was quite really, yeah, just the information that, you know, receiving and translating it was all difficult.
So often there might be an interpreter there or a family member there, or hopefully both. But if that person isn't allowed into the room where they're doing the procedure, then I guess there's an additional problem there with a lack of being able to have an interpretation during the procedure. Henrietta, what strategies do you think that can be implemented to bridge language barriers and improve understanding of cancer diagnosis, treatment, and follow-up care? Anything on the cancer journey? Yes, can you unmute? Do you want me to do it for you?
Yeah, thank you. No, it's for some reason the system just locks me out. So my apologies.
I'll do it for you when I ask you a question. My name.
It's a really good question, because the reality is, as mentioned in many scenarios, language is a very key component of engaging with the families, as well as obviously with the person. And sometimes the families are in between the person and the doctor. And, you know, even just remembering that when the diagnosis is new and this is the first time that is shared with the family, the first wave is hit the family and they have to process it on the side, deciding if this is, and often and not, a lot of the feedback were that they're deciding on the spot how much to tell to the person, you know, and then just deal with the repercussion later on. And this is why, obviously, engaging with these professionals who making or talking about the diagnosis, about how this, you know, if they know that the family is translating, that they need to, you know, there's going to be the first wave of shock, and that can actually determine how that information is passed on to the person. So again, building that trust with the family of using an interpreter so everybody understands at the same time. But again, the families may be protective, as well as often than not, when it comes to information provision, what I'm seeing in a lot of the multicultural plans, and it did came out from this specific one, multicultural action plan and diversity action plan, which are fantastic and really, really needed, is that they say they're going to use TIS or they're going to translate to 10 languages. But that's not an action. That's just one, you know, and if you're lucky, you are in a office where the doctor knows how to use TIS. You are lucky if you are in that 10 languages and able to get the translation. What I would love to see an actual plan would be responding to minority languages. So, okay, we don't have that translated, but by the sounds of it, do you need it, and expressing that need, and based on that, able to translate. So there's the ability to translate and also the budget for it, because obviously it's very important. So interpreting and translation, often, and what I'm seeing, and again, this is the systemic barrier, the other side of that fence. We love to talk about the barriers of the clients and families, right? But it's the other side of that systemic barrier where we still think that languages is a barrier. Languages are bridges. We need to use them. They are not barriers, they are bridges. And this is how we should act on our diversity plans, because otherwise we're going to end up situation where could have been translated, but it was not responsive, and the families had to do the translation, and then all a repercussion from that. So I really think what I would love to see is that translation and interpreting is used as a tool, and languages are looked at as bridges and not barriers. Thank you.
Thank you so much, Henrietta. I think that's really well put. Like, I think even when you read the research, there's a lot of focus on individualistic barriers rather than the systemic nature of a system that's set up not to be able to, set up for poor communication, really, in terms of some of the issues that occur. You've got I can see lots of love that Henrietta's in your in the chat there. I would like to move on a little bit to information and resources. So as a follow-up to the 2022 project, the Department of Health has asked Cancer Council and ourselves, Health Consumers Council, in conjunction with a lot of community organisations and consumers, to create some new resources, videos and written resources, which include checklists of questions to ask your doctor, which I think is going to be great. And it's great that they're putting the money behind developing those, and also doing that with consumers, which I love. And we're going to translate into 6 languages, which is just awesome. But of course, if the resources sit there on a website and aren't utilized, you know, that's the concern. So I'm just wondering, sticking with you, Henrietta, and I'll unmute you, if you've got any ideas around strategies for ensuring that, or doing our best to ensure that any resources that are created really do reach the people who need them.
This is always a big question, and with any resources that we're trying to create for the communities. And the reality is, what I've seen from our engagement through the Care Finder program or the Encompass Multicultural Connector program, is that face-to-face, then, you know, multifaceted. Often than not, we think one thing going to solve one particular problem, but the reality is we're taking that resource and tool to the communities, and often than not, they come back with 3 different answers. So again, being flexible of what we are learning about these tools, properly monitoring it, how the videos are viewed. For example, you know, for us, they asked for face-to-face. And as I said, I think we had that discussion before in one of the meetings, that the videos that you are creating are fantastic, but it's going to be more likely a tool for me or facilitators like myself who go out to the communities and going to show them through different presentation and engage with them on that topic of what did you understand? How did you understand? Is it, you know, really deep diving into the video? So the video could be a tool, especially for facilitators. So getting into organizations that are engaging with communities and they can get this information to the communities will be really important. And then promoting it from there. So I think it will be gradually. And also I would like to caution everybody to rush with this. This is new. We haven't done this. And if anybody is expecting in 6 months that we're going to revolutionize the whole world and everybody aware of cancer, unrealistic. I would give 5 years by the time it's slowly slipping through those cracks, because people change, people move, but the communities are still there and struggling with a lot of these things. So I really hope that in the next 5 years, we will gradually roll this one out and slowly getting into the corners of those communities that are really needing it. But it will take time, because trust have not been built with these communities. It's great that we're developing the resources, but now it's on our end to deliver those to communities that are really needing it and building the trust. But I would caution rushing this, and I really hope that this project will be funded longer term, because we will need that to make sure that it will have the proper impact.
Thank you, Henrietta. And I agree that we do need to sort of build those community connections and trust. It's something that's starting and increasing, I think, more, but it's something that we need to do a lot more of. Hafida, you work as a community connector down in Katanning, don't you? Could you tell the audience a little bit about the work that you do there?
So the work that I do as a community connector is firstly, I would like to say, awesome, Henrietta. I really agree with what you've also had spoken regarding about the resources and the video, and it takes a while. And then yes, community. It takes community to go in. No, majority of our people don't read and write. So with the resources, it's kind of like waste of money. So we, as community connectors, need to go out there and support the families and the people that actually going through you know, their cancer journey or whatever journey they're going through. So, you know, we are the first people, you know, trusted community members that they come to. Yeah.
Thank you. And I'd love to hear from our other two consumers, Samira and Leon, about what information or resources you received along your journey, or services that you were referred to. I'm interested to know if either of you called the Cancer Council, for example, and if there's any other information and resources you received. Samira, do you want to see you're unmuted so you can?
But no, I didn't receive any information. I didn't know about where to contact. I went through the cancer journey for about more than 1 year treatment, and then I had no help. So the only thing I received when I was in the chemotherapy, I was undergoing chemotherapy, was just, you know, look good, feel better, fly. They gave me that one, and then I
went. You
went
liked that one though, didn't you? I remember you saying you really liked that one. Tell us about it.
quite happy, you know, because I was going through chemo with 3 little kids, and then I had no support from anybody. So I had to go to all my chemo by my own, alone. I went through all the treatments just alone. I went to my surgery with a train. So because my husband was looking after the kids, it was hard. Then when they gave me that one, and then I was hairless, you know, all my hair was full. I was happy. I found the room, and then we went with a few friends. You know, I found a few friends in there, talked about the cancer, and then they showed us how to deal with it. It was a joy for the day. But the rest, I didn't know actually about any physical activities they do. At the time I was in Rockingham, so I didn't know about the area. I didn't, so.
Thank you.
Yeah, please.
Leon. I'm going to unmute you.
Okay, thank you. But I think the individual choice maybe will decide what kind of resources they want or how do they acquire to get the resources. My wife herself is a scholar. Actually, she pretty like use the internet, like Google everything there. But the additional information is about the cancer, whatever kind of service available in WA, it is not started. I think in the 3rd year of the treatment of the cancer. For first 3 years, the targeted therapy was quite successful. She just took the tablets and do whatever she want. She just live a very normal life. But when the body developed a kind of resistance in late 1999, she went to the conventional, to the traditional chemotherapy, and I accompanied her to go to the Fiona Hospital. While she was treating there, usually waiting quite long there. So I went to kind of maybe the tea room. They got the bookshelf. They put quite a lot of the flyover or just a pamphlet. So I read a few there, but I'm not interested either because more like just very general knowledge. We do have it, and also I did the cancer council phone number. I asked my wife, shall we call them? My wife said, no, we didn't. So actually, throughout her cancer battling, fighting, we didn't call in service actually. So the all resources we get from Googling that from internet.
Yeah.
I think that one of the reasons is because she didn't want to close her problems with all friends and family members except even my son. I think he did not know the mother got cancer until he overheard from doctor once we got the emergency there. So that's why she was very resilient, very tough lady there. So actually, she thought she could survive. And even before she died, maybe just in 1 week ago before, she was died in the war. She still thought, it could overcome all problems. So yeah, I think the individual choice, or where do we get, or where do we get resources, or if we need the resources, it can be personal choice sometimes, not just we get enough resources available for them or not.
Yeah, I think it's really important though not to put the onus completely on the individual, like in terms of having health information explained to them, having things that patients and families can refer back to. And there's so many services out there. I think making them accessible to all people is so important. But you touched on something there. You have mentioned to me before that you didn't tell anyone within the family about your wife's diagnosis until right at the end. And I was interested. So am I right in thinking it was partly to do with not wanting people overseas to worry? Can you explain that a little bit more to us, if possible, if you don't mind?
Yeah, my wife, I think she always thought if she would disclose the disease, the conditions, maybe get some prejudice from the society, from the community, or even just the kind of sympathy she thought she didn't need it from the other friends and family members. But she was very, very tough, actually. She thought she could survive, and she could, at the end, live with the cancer. So that's why we did not inform both sides of the family, my family and her family, until she passed away in 2021 until July of 2021. So that's just 5 months in advance of that. My son did not know her mother got cancer. I think it could be the May or June of the 2021. She got fever from the chemotherapy, and as emergency there, we took her to the hospital, and the doctor told about the cancer. He overheard, he cried. Because why you covered the story so long there? The reason, I think one of the motive for mother of his mother, 1996, he was 16. He was 15, turning 16 years old. We thought it was too young to know to carry such psychological burden. And so we did not say that. And the treatment at the beginning pretty well. We all thought we could live even 10 or 20 years. So that's what we expected. It's unnecessary to let the son know that, because she lived quite a normal life. So sports, conference, meeting, dinner, party, everything was daily as she was attending as normal. So all friends were shocked. I think 5 days before she died. So we informed all the friends because she was a critical condition. So they all visit us with a big shock. So that's her story there, because her personal belief, if she did not want to be treated as a patient, so she wanted to live a very normal life. So that's the reason.
Thank you, Leon. That makes me think about sort of some other cultural beliefs, practices that might impact cancer care decisions. Soy, have you got any thoughts on? Without, I know it's difficult. We don't want to generalize, and it's important not to do that when we're talking about different cultures. But we have had a conversation before about some of the different things that people from different cultures think around cancer. Could I ask you to share some of that, please?
Yeah. Before I answer your question, can I point out 2 things?
Sure, please.
One is about Leon regarding the information or where to seek information. I need to point out in 13/11/20, where we work, all incoming calls are confidential. Whatever conversation taken in the room where I am, it will stay in the room. Let's say if a wife phone in and the next minute is the husband phone and say, did my wife call? I cannot say yay or nay. I can't deny, I can't say yes, because it's confidential. It is up to the wife to disclose to them. So I think that's very important for the community to be aware of this. The other thing is about the interpreter. When the interpreter is not allowed to go into the procedure room, I was thinking that through my working experience, you can have the interpreter to actually talk with the patient, with the health professional at the side, and explain to her the whole concept of the procedure. That would give her some idea of what is to come. So it's always the fear of the unknown that lead to that sort of discomfort and not wanting to go ahead with the procedure. So maybe to explain the whole thing in advance to make her aware and allow her to be in control in some way. Come back to...
Sorry to interrupt, but just picking up on that point, when I was doing the interviews, I heard a similar story about somebody who had an interpreter present, but then they couldn't go into the room where a biopsy was taking place, and that patient didn't understand that what the biopsy was going to entail. And then when the needle came, towards them, they were quite anxious and quite worried. And I think, that's the sort of thing where we need workarounds around whether it's the privacy and the interpreter that, can come a certain way with them, whether it's briefing a patient beforehand, whether it's using images and icons and explanation, whether it's using a telephone interpreter. I suppose these are the sorts of things where we've got to kind of think outside the box a bit, because I remember hearing that story and thinking about a person lying there with a unexpectedly large needle coming towards them. It did not go well in terms of that patient's or family's trauma and experience. And my understanding is that there was, with that patient, a family member and an interpreter present, but neither was allowed into the... I don't know if that was a COVID thing or what, but yeah.
I think
especially...
Sorry,
let you answer the other question that you were going to answer.
Okay. Now, with the community's belief, now this is definitely not a generalization. I would say the belief also depends on which country you're from. Let's say a Chinese could be brought up from Taiwan, China, Singapore, Malaysia, or even from England. And that will affect some sort of a belief in them. Again, it also depends on the family upbringing, and the kind of a family background they have and the education. So that will come into that sort of a display. A very common thing about the belief is, in a simple word to say karma, probably that's how we interpret. But in Cantonese, we say 因果報應, and in Mandarin we call 因果報應. It basically is explaining that, let's say if a parent or both parents have done some bad things in their lifetime, they're accumulating bad deeds. Now, they are not going to be affected by that. It would pass down to the children, the next generation. So when the next generations have bad things happen in the family, illness, unfortunate events, death, injuries, and things like that, they will start questioning what happened. Am I going to repay because of that? And some of them would believe that it's destiny. They can't change it because it's already done. So it's payback time. In fact, I've come across a case in the private conversation. He's actually in his late 60s. And he told me, whether I have the treatment or I don't, to me, it's irrelevant. It's destiny. It's probably that's what I'm going to face. So what he did was he left the decision to the children, and he go along with the children because he didn't want to make the decision. He just feel that there's no way out for him. And it's such a sad case. And I hope this would not kind of spread out in the community in that sense, because I always believe when there's a chance you fight, you can still do it. And the other belief is, it depends also, again, in which community you are in, the group of communities, like in a certain village. if you have been diagnosed with cancer, people didn't want to go near you. They think you're infectious. So that is one thing we have to do to make sure that's being explained to the patient, also filter out to the community. It is not infectious. It's okay to say the word. It's okay to let your friend know, because then you have more support. Trying to do it on your own, it is very difficult.
Very difficult. Yeah.
More than difficult, beyond belief. Yeah.
That's
Sorry?
Oh.
Yeah.
You were going to
Samira, you were just acknowledging, yeah. And I know when you talked about your husband not being able to come to the appointments because he had the 3 young kids at home, I think, you know, migrant families were often here with no grandparents for the kids, no support, small networks. And if you're not sharing that issue with the wider cultural community, it can be really difficult to manage these things.
exactly.
Alone. I feel maybe before I gather from my colleagues that there isn't many questions in the chat. So unless if you've got a question, please do put it in. Otherwise, I'll just carry on with my questioning. But I was wondering if any of the consumers would like to talk to some of the best things or most helpful things that they found during their cancer journey. Hafida, Leon, Samira, any comments on things that worked really well?
I'll make a little comment about the system. So, seems to be in WA, we do not have enough staff as nurses. So, I'll give you one of the examples which I'm very, very sad and stressed. Well, my wife was the last week of life. I think it could be she got critical condition in December 5th. But on December the 4th, usually, those days, I would accompany her until about 9 p.m. before I went home. So before the critical condition. So, or I recall could be the 3rd, the 4th of December in the morning. I went to see my wife. She was sitting on the bed, looked blankly, and she was crying because actually it's a side effect from one of the chemotherapy. Her hands could not move, and you know, the oxygen support is off the nose. It's ironically before I left on the, I think on the previous evening, I told the nurse my wife got trouble there. She could not even press the button to call help. And could you ask them, could you please regularly check if the oxygen support is still there? But when I went there, actually the oxygen definitely is off the nose, and she was breathless, and oxygen dropped to like 75. And yeah, I was very angry actually at that moment. And also, because the big problem is actually she wanted to use the toilet at night because when you know just the coordinated of the urine there, but she did not know how to press the button there because we couldn't move the arms, and she cried. She told me she got very big problems with the kidney there. She thought there because she hold the urine for the whole night there. And starting from that day after that, the urine never go up until she died. So they have to use, the some bivalent there, induction way to get the urine there. So that's the worst experience. Another example is on the, I think the October. Sometimes the doctors, maybe they were busy or maybe they're arrogant, got big trouble with another doctor. It's not the cancer doctor. She got fever. Then we went to, because it's the pandemic time. So we went to the Fiona Hospital and they sent her to, I think the 5th level there is about breathing there. She stayed there for a couple of days. And my wife still complained, so I still feel breathless. And the body temperature seemed to be dropped, but it wasn't. I think it's the effect of the medication, could be Panadol there. And she begged the doctor, said, "Can I stay here? Because my home we do not have oxygen support." The doctor, "No, you must go home." So on the same day there, she went home. just 2 hours, body temperature rose again to 41 degrees. So it was not once it stopped the medication there, and the oxygen dropped to 75. So I have to drove her to the hospital on the same day. So we also got very close with the the doctor, because sometimes the patients know the symptom, they know the body there. She begged him, "Oh, we could not go home, so otherwise maybe die at home." But the student, I think he drove her home, and on the same day we back to the emergency again. So this could be the worst experience with the the system here. So then I thought, oh, maybe they do not have enough wards, they did not have enough doctors or nurses. But this is a big trouble there that we experienced for the whole procedure battling against the cancer of my wife.
An important emphasis on the need for patient-centered care there, and the fact that patients, families, parents know their own bodies and
Definitely. But the doctor sometimes won't hear that.
Now I'm conscious of time, and I had so many other topics on my list. Henrietta, sorry. Yeah. Go on. Oh, let me unmute you. Hold on.
Unmute.
Hopefully I'm unmuted
No,
now.
it's
Yeah.
back again. And again, I thank you so much for sharing that story. And it's just heartbreaking to hear these are the outcomes. And again, the person-centered care, like that's what we're asking. We're not asking for anything more. If you center the person in the care, they would deliver. So that's my only message of, we're not inventing the wheel here. We're not asking for the moon. It's just literally, if we would have actual person-centered care, I really hope that we won't have these kind of stories. And again, I'm very sorry. This is absolutely, thank you so much for sharing as well.
Thank you, Henrietta.
And
So
educating.
sorry.
Thank you.
I agree with Henrietta too, Leon. Sorry, that was your experience. And like you say, we're not asking for the world on a stick, moon on a stick. We're just asking patient-centered care. So that actually, because I am conscious of time, probably leads me to go and ask all the panelists, if you had one thing you wanted health providers to know that would improve cancer care for culturally and linguistically diverse patients and families, what would it be? The big question. Who would like to go first?
I would like to go first.
Okay, great. Hafida, kick us off.
Like listen and like be present, like just, we're coming in, from the country, from anywhere, that 5 minutes, just be present and be kind and really, really listen with compassion.
Thank you very much. And I realize I asked a question earlier that I didn't give you or Samira an opportunity to answer. But if you have anything, Samira, are you itching to tell me something positive before we go to the last comment?
Yeah, that's right. So during my all sessions of chemotherapy, radiation therapy, and reconstructive surgery, I came up kind of a lot of good people, doctors, nurses. They were very kind to me. Actually, they were so helpful. During my reconstruction, I was in a intensive care unit for 5 days. And then they used to come and comb my hair and, looking after me, give me a positive words. You'll be fine. You'll be like 15 years old again. Those kind of things, they helped me a lot to pass my journey. I really appreciate what they did to me.
Thank you. So you appreciated people going over and above, bit of time, personal attention, positive comments. I know you've said to me before that sometimes, like I'm the sort of person that likes to have all the information up front, no matter how negative it is, I'd rather know. But some people, really benefit from a lot of that reassurance and that sort of thing. Anyway, so thank you, Samira. And if there was one thing you wanted health providers to know to improve things, what would it be?
Just give the patient, the doctor, the oncologist, when they tell the patient that thing, even if it's the worst thing, just give them a hope and give them an example, a positive stuff, and then that will be very helpful for the patient.
Thank you, Samira. Soy, anything you'd like to add in terms of what you'd like health
Yes,
providers to know?
I think in my line of work, from mental health, midwifery, general nursing, up until now cancer nursing, emotion is something you cannot avoid. Therefore, I would say I would like all of us who's involved in this line looking after our patients with compassion, empathy, with understanding, and looking from our patient's perspective. Now, on top of that, I also want to add on, we have encountered a lot of calls that they have issues with transport. We really need to have the government or other hospital, private sector to look into improving the transport system, because I have 80-year-old guy phone in and say, I couldn't get there. I have no transport. I think I'm not going to go for the treatment. So it's defeated the purpose. Transport is a very much kind of a issue there for the cancer patient. Yeah.
Thank you very much, Soy. I think Hafida mentioned a bit about that as well, coming from the regions. I know there are options in terms of PATS and the lodges, but it's not available for everyone for everything. So good point. Now, I noticed...
And accommodation too. If it's full, it's full.
Now, so I've got Jessie from the Department of Health in the chat. You've said you'd like to add something. Is that something you wanted to add out loud to the group, or are you going to add a comment in the chat there?
Yes, Kaya, can everyone hear me?
Yes.
Yes.
Hi, well, nyalakan karajan nunga buja, Kaya wanjun ejanalak nunga bujara. That is hello, welcome to my country here in WA on Noongar Whadjuk country, Bulu, here in Perth. Thank you for everyone's time today, and it's been an absolute privilege to be in this space and listening to everyone and the information and the knowledge that they've been giving, especially to the consumers as well. I would like to add, not bringing your cultural biases into consultations or your practice as well. When you're in this space with culturally diverse people, it doesn't matter whether they're Aboriginal, Torres Strait Islander or not. There are a lot of multicultural people here who live in Australia, and Australia is multicultural. So understanding Western-centric hegemonies and challenging those dominant narratives as well is very, very key in reflexive practice for clinicians, and also sitting deeply and listening to those patients as well, and placing that care at the center of people as well, and clients, and understand what is being said in the silence too as well, and really reflecting on body language in those spaces too.
Thank you so much, Jessie. I think that's so important. Like, we talk about person-centered care, but how do we achieve that? And sitting deeply, listening, body language is so important. And I think, you know, particularly some of the higher context cultures that we have in the East, a lot comes from words that aren't necessarily said in any language, in terms of how we communicate. That's certainly in my culture, and I think many other Eastern cultures, Aboriginal culture, Torres Strait Islander cultures. So we are coming to the end of our time. Thank you so much for sharing. We are coming to the end of our time. My colleagues will put a feedback form in the meeting group chat, and I'd really appreciate your feedback, because anything we can do to improve our sessions is useful. I will just say before we go that we've heard some really moving stories from our consumers and community representatives today. Some positives, but also some explanation of disparities that result from a fragmented system, which is hard to navigate, a lack of appropriate and accessible health information, some cultural biases, and possibly a system which is an environment in some cases of poor communication. So these are things that we continue, all of us in our practice here, to try and improve. And I think if you're on this webinar, then you're obviously in that space of trying to improve things. I'm really delighted to be working with Cancer Council on the development of these new resources, and we will share those with you when they're ready, and I look forward to that. Melanie's also shared the cancer helpline that Soy, don't think it's called that anymore, 13 11 20, which Soy works on if you or your family is affected by cancer. And yes, I just want to say thank you very, very much to all the panelists. I really, really appreciate your time today. To Umbrella, Cancer Council WA for partnering on this event, to my colleague Kieran, and for anyone who is starting today or tomorrow and celebrates, then Ramadan Mubarak to you as well. Thank you very much.
Thank
Bye-bye.
you. Bye-bye.
Thank you.
Zoom wave.